Good afternoon, everyone, and welcome to the Fireside Chat discussing advancing health equity with patient assistance. I'm Krista Zodette, President and Chief Executive Officer of the HealthWell Foundation. And with me on stage is my wonderful panel, and I will let them introduce themselves. Fran.
Hi, I'm Fran Costello. I'm the President of Operations for Patient Advocate Foundation.
Hi, good afternoon. I'm Patty Falconer, a Strategic Advisor for Atlas Health.
Good afternoon. I'm Jerry Scarzella. I'm the Vice Chair and Treasurer for HealthWell Foundation.
Hi, everyone. My name is Sarah Paul. I'm the Director of Clinical Programs at Cancer Care.
Great. So health equities is a pretty broad category of discussion, and we have a lot to cover today. So in order to make it a little bit more manageable, when we're talking about patient assistance, we're going to be really focusing on charitable patient assistance programs that offer financial assistance to patients to help with their medical treatment cost shares. So step one, to kind of make it a little bit more manageable. We will also be focusing on health disparities related to cancer. However, we do believe that the learnings we discussed today can be applied to other areas as well. So we'll be keeping good notes on those. And finally, this is really the beginning of a bigger discussion. And it's meant to get people curious about what we can and can't do and what we should be doing related to health disparities in patient assistance. And I and the panelists will be available for further discussion in the exhibit hall during the reception this afternoon. So feel free to stop by. We'd love to talk to you further. And with that, because we have a lot to cover, I'm going to turn it over to Patty to frame the discussion, sharing some data from the patient assistance world related to health disparities. Do you want this one?
Yeah. Hello. So as a cancer survivor and a caregiver to my mom who had breast cancer and the former executive director of cancer services at Stanford, I am really happy to be with you today to be talking about this very important and beginning this very important conversation. Thank you to HealthWell for participating in a research study that was presented at ASCO earlier this year, and for allowing the deep dive into their data to tee up our Fireside Chat this afternoon. So big shout out to Fred and to Sam, who did the heavy lifting on the data. Thank you. As Krista mentions, our discussions today will focus on cancer patients, but the learnings can be applied broadly to other patients experiencing complex, chronic, and perhaps life-threatening diseases like diabetes, cardiovascular disease, and MS. If you would change the slide. Why is it important to advance health equity? Advances in cancer care and treatments have improved the quality of life, the quality of care, but may not be available to all individuals. Socioeconomic inequities in cancer mortality have widened over the past 3 decades. Cancer health disparities are the difference in cancer measures, such as the difference in cancer incidence, deaths, complications, or screening rates. We see that cancer health disparities persist for members of racial and ethnic communities, people with disabilities, members of the LGBTQ community, individuals with limited English proficiency, members of rural communities, and individuals with low income. Shockingly, Black patients have the highest death rate and the shortest survival of any racial ethnic group in the US for most cancers. Next slide. Another reason to advance health equity is the opportunity to reduce financial toxicity. And the same population of individuals we just discussed are at the highest risk for financial toxicity. And many of you know and experience this every day in your work. Financial toxicity is the financial stress, strain, and distress that patients experience as a result of their diagnosis, and the coping strategies that patients and families use to manage their financial situation. I had the privilege to speak at one of the Chronic Disease Day events with Good Days, and here you see the word cloud representing participants' response when asked, what is one word that describes your experience with financial toxicity? So 22 to 50% of cancer patients report financial toxicity during the time of their active treatment. and unresolved financial distress is linked to clinically relevant outcomes, such as quality of life, treatment adherence, symptom management, and survival. Next slide. As patient advocates, whether you work for a hospital, whether you work in a health system, for a medical group, for a drug manufacturer, or a charitable foundation, or if you're independent, you may not have the data to understand the socio-demographic characteristics of patients receiving copay assistance or those left behind. Often performance metrics are measured by productivity or dollars, and program metrics that actually measure reduction in healthcare disparities are not widely understood. Next slide. Copay assistance current program design may not reduce healthcare disparities without intention. We need a structured approach. The CMS framework for health equity was designed to help organizations achieve health equity and reduce disparities among minority and underserved populations. Since the majority of cancer patients are Medicare eligible and charitable foundations serve many Medicare patients, this framework is a good fit. The CMS framework for health equity defines which socio-demographic data needs to be collected. As you can see, this data ties to the health disparities we reviewed in an earlier slide. In current state of this list of standardized data, HealthWell collects only grant applicants' sex at birth. The CMS framework also establishes 5 priorities, which provide an integrated approach to build health equity into existing and new efforts by CMS and its stakeholders. Priority 1, expand collection, reporting, and analysis of standardized data. Priority 2, assess causes of disparities. 3, build capacity. 4, advance language access, health literacy, and culturally tailored services. And priority 5, increase all forms of accessibility. Next slide. So what does current state data tell us? Dr. Jeffrey Peppercorn, the Director of Supportive Care and Survivorship at Mass General Hospital Cancer Center, and many of his colleagues at other NCI comprehensive cancer centers, conducted a national cross-sectional survey of copay financial recipients from HealthWell Foundation. The survey included 1,108 cancer patients who received copay assistance grants. The primary outcome of interest was patient self-reported financial distress. The survey results will likely not surprise you. 56% of the survey respondents reported mild, and 27% reported moderate to severe financial toxicity. 17% reported delays in starting therapy. 18% reported skipping medical services due to cost, and 24% of the respondents believed they would not have received treatment without financial assistance. Next slide. But we can't rely on research alone to help us address health equity, as research participants may not represent all patient populations. The national survey gave us a small snapshot, given that HealthWell's total number of approved grants for cancer patients in 2021 was over 68,000. We will now compare the cross-sectional survey data to HealthWell's Cancer Disease Fund recipients in 2021 and 2022. You will see some similarities, such as the tumor type mix, age, male-female ratio, and the high percentage of Medicare recipients listed on this slide. Of note, you see that the participants in this study were 88% non-Hispanic white and 55% college educated. Those demographics may not represent the total population of HealthWell's grant recipients. Next slide. So let's look closer at race and ethnicity. Collecting data on race, ethnicity, and preferred language for individuals applying for copay assistance is a critical step to identify potential disparities and then determine how to address them. When we compare the race and ethnicity composition of the participants in the national survey to the rate of new cancers in the U.S. by race and ethnicity, you see a significant difference. The data suggests that the race and ethnicity mix of HealthWell's cancer grant recipients, it likely looks a bit different than reported in the national survey. Next slide. HealthWell, as you see, has an incredibly robust list of cancer disease funds, 39 representing oncologic and hematologic malignancies. And this is a larger number than was represented in the national survey, which was 20. 33 are defined by primary cancer diagnosis, and 6 are defined by secondary cancer diagnosis, meaning for supportive care medications. Next slide. Here you see some of the data for HealthWell Cancer Disease Funds for 2021 and 2022. For 2021, $325 million in total cancer grants and $342 million in 2022. In 2021, 20.1% of the grant recipients had family incomes that fell within 150 to 200% of the federal poverty level. And for a family of 4, this is similar to the income that's less than $60,000 reported in the cross-sectional survey. Next slide. Advancing health equity presents a compelling reason to look at data collection and analysis through a new lens. Given social drivers affecting cancer outcomes and program elements of copay assistance, the additional data for consideration would be race, ethnicity, preferred language, gender identity, sexual orientation, disability, and educational level. We need to acknowledge that there is a tension between elevating health equity and collecting more data from applicants. Many charitable foundations find that asking patients for more information may present a barrier to enrollment. And there are concerns about how to frame the questions and the timing of the data requests. Others may not have access to evidence-based questions, and many have operated under the notion of the minimum necessary data requirement. Next slide. But additional data may yield new opportunities. So to reduce healthcare disparities, disease-based funds for patient populations with the highest incidence of cancer would have the highest total grant amounts. In this slide, the 2022 total grant amount, approved number of grants, and the average grant amount per patient for each diagnosis-based fund was compared to the new cancer cases per year and the NCI, or National Cancer Institute, 5-year survival rates for the overall population. The NCI 5-year survival rates is the percentage indicating the proportion of people with a particular cancer diagnosis that will be alive after 5 years. Next slide. Oh, stay here for one more slide. Go back. Thank you. Prostate cancer shows the best alignment. Prostate cancer is the number 2 most prevalent cancer across all populations, and the number 1 most prevalent for Black and Hispanic men. This is the largest cancer disease fund, $47 million, and prostate cancer has a 97.5% 5-year survival rate. Areas of opportunity include the breast cancer disease-based fund, which is $7.9 million. This fund is small, given that breast cancer has a 90.3% 5-year survival rate and is the most prevalent cancer in women across all populations. For Black and Hispanic women, breast cancer has a significantly greater mortality when compared to white women. And there are no available funds for uterine cancer and thyroid cancer, even though these diagnoses represent the 2nd and 3rd most prevalent cancers for Hispanic women. So data representing these gaps will be useful to identify new philanthropic sources of funding and health equity grants for oversubscribed or missing disease-based funds. Now, if you would change. Accurate referral data is essential to determine potential health disparities. So what you see in this slide is 2/3 of patients were referred to HealthWell via their portal, which helped reduce enrollment barriers for patients. 1/3 were directed to HealthWell's website or hotline to self-enroll, and those were mostly directed by pharmacies, providers, and other copay assistance programs. To increase the opportunity for patients to be enrolled via the portal, Healthwell is developing a pharmacy portal. An increased use of the Healthwell portal would support greater access to copay assistance programs. Next slide. We know that health literacy and the English language proficiency can play a very big part in aiding patients to self-enroll in copay assistance programs. 1 in 6 cancer survivors report low health literacy, and low health literacy is more prevalent in Black and Hispanic cancer survivors and those with lower educational attainment and lower household income. The percentage of time that patients asked for a language interpreter service when using Healthwell's telephone hotline is low compared to the percentage of individuals in the US that do not speak English as their primary language, which is 21.6%, suggesting that there could be barriers to accessing copay assistance programs for non-English speaking patients. The complexity of enrollment is mitigated when applications are completed on behalf of patients using the Healthwell portal. Next slide. So today's deep data dive suggests a number of next steps. To evaluate establishing health equity as a strategic priority, to review what it would take to implement best practices aligned with the CMS framework, to collect socioeconomic or sociodemographic data for patients receiving copay assistance, and for those that are not eligible, ensure linguistically and culturally appropriate programs, and establish processes for data collection. And lastly, to perform ongoing analysis to determine and resolve disparities in access. Next slide. Thank you, and now I'm going to return the presentation over. Oh, come on up to Krista.
Great. Okay. Thank you, Patty. So what we're going to do is I have some questions for the panelists to kind of walk through, and then we'll definitely have some time at the end to open it up to audience participation. So the first question is, patient assistance programs typically include income thresholds or limits as part of our eligibility screening. Sarah, I wanted to talk with you first. So Cancer Care is based in New York City. It's a high cost of living community.
Yes.
Can you speak to the challenges of income limits many patient assistance programs have as part of that screening?
Sure. And it's not only New York City, any high cost of living community will experience this, but many times, people that are in the middle class, whether it be lower or upper middle class, on paper, they look like they can afford their cancer treatment. They look like they don't need assistance, especially in applications at first glance. And what we're seeing is people are falling into this middle income trap, which is this gap, for people that don't qualify for patient assistance programs or charitable patient assistance programs, which puts immense financial strain on them. And this affects all communities, right? We see underrepresented communities working really hard to establish themselves, and then a cancer diagnosis will change everything. And then now they can't afford their treatment because they make too much money. Make too much money. So we see this trend, and it's really difficult to also refer patients to other programs because everybody has FDL guidelines and they're very similar. So it puts a lot of stress on them.
Great. Fran, as a fellow CPAP, have you thought through, or any way that we could get around the legal and compliance and beyond adjusting for a high cost of living area? And could we do that without becoming administratively burdensome? Is it even possible? I'd love your thoughts on that.
Yeah. So I think that's $1 million question. Those things don't always go together, but I will say that I do think there's some ways to more strategically allocate resources, specifically to maybe patients in higher income levels that appear to be not in need, but they are. And more importantly for our organization, those in the very low income levels that we're not even reaching because they don't know about us and they don't have anybody helping them at a pharmacy or at a doctor's office. There are some things that have been done through the years. We've done some of them. For example, we do adjust for cost of living based on zip code. So the income in the $50,000 income in Kentucky is different than it is in New York City based on cost of living expenses. I think that's really important to normalize that income. We could consider some different surrogates for income and tax returns, or some things to decrement those that total AGI, if you will, like medical debt. Maybe they have a kid in college and they're paying college tuition. Maybe they have a bankruptcy or a garnishment that's going on. So documentable financial distress or financial issues that they may be facing that are really making them look on paper that they don't need help, but in fact, day to day, they do. So I think the trick is the administratively easy part of that, because there's no single data source to go get that kind of information. There's not a garnishment database that we could all go electronically pull those things from. So I think that will be it'll be a trade-off, Krista. We'll have to make some decisions. Does it make sense to invest a little more manpower and have those avenues for patients, and realize maybe it's not as efficient as we can do other things, but it's the right thing.
Right. And I think, too, yesterday when we were talking with Matt Howitt from the DOJ, so as you might know, the CPAP space we're highly regulated. We have to follow a lot of different guidelines. So we had the opportunity to kind of ask some random anonymous questions to Matt Howitt from the Department of Justice, and we specifically asked about where the DOJ is landing with the FPL limits that we have on our programs. And he, of course, he can't give us a straight yes or no answer, but what he did say, and I circled my note, it says, if you're going to go something 800% or north, be prepared to defend it should the government ask. So I think we have that wiggle room, but I think when we were talking about that just now, prepping for the panel, the charitable programs have to balance, we have limited funding, right? So it's our funds closed. If that was a bottomless pit of money, absolutely, let's go up to 800%. Let's defend it. Let's get everybody in. But we only have certain amounts of money that are being donated into those disease areas. So we have to make that call at some point. There always has to be a line for our eligibility screening. And we do try to balance that. And it's something that I know HealthWell has grappled with it. We've talked with our board multiple times about it. How do we balance these things? So that's kind of another, I think we have an avenue to do it compliantly now. But it's kind of how do you balance kind of going up higher on one side, but knowing that the funding is not growing with that added burden. And Jerry, again, still related to kind of the financial piece of, these limitations. During our planning session, we talked a little bit about creative budgeting or creative spending. And I was wondering if you could share with the group kind of what that is and talk a little bit about that.
Good afternoon, everybody. Thanks for being here. So when we talk about creative spending, it's a mechanism for freeing up or reshifting, moving things around a little bit to help patients, moving around those monies or resources, to help patients get better or best experience that we can give them. I kind of look at it as, when you're driving in your car. Siri hates me in my car. She said some nasty things to me once, but when she says, when you go the wrong way and she says recalculating, and she has to refigure out the route because you didn't turn where she told you to turn. That's kind of what it is. We have to recalculate. We have to think about that. And one of the things when I think about this is the patient who has balls in their hand that they're juggling. And they're juggling all of these things going on in their life, all of these add-ons that they have, childcare, food, travel, all of those things that you've heard about all week long in the different sessions that you attended. But one of those balls is glass. As they're juggling, any of those balls can fall, but to that patient, one of those things is the most critical that they can't afford to let it fall. So when we talk about shifting those things, for an example, one example would be a patient who has an air quotes affordable copay for treatment, but they haven't ever thought about or sought out some help for that or some pursue copay foundation or assistance, but they're struggling to pay for the child care when they go for their treatment. So one of the things when we talk about creative spending is looking at a different way to help them manage that. As advocates, perhaps you can get them involved with a copay foundation that then pays for their treatment. The money that they were using for their treatment can now be put toward child care. So that's one way to look at it. I again try to look at it in words of people, and I try to make things process in my head. And my late husband had a very particular statement that he would say when I would go home sometime as a patient advocate, and I say, I'm stuck. I don't know what to do with this patient. I don't know where to put them. I don't know how to help them anymore. And he would say, change your ideas. I'm like, no kind of help. What do you mean change my ideas? What's wrong with you? But now I understand what he means. When he said change your ideas, when you're stuck and you can't figure out what to do for your patient or how to do creative planning for them, what he was saying to me is, you're stuck on that idea. Change your thinking and you'll open up other options and opportunities to help your patient. So I get it now, and I hope you use that as well.
Great. Fran, did you have anything to add to that?
Yeah, I mean, I just want to reiterate what Jerry, I'm sure most of you in this room that work as independent advocates and advocates within facilities do this all day, every day. We have a team of case managers at Patient Advocate Foundation, unrelated to our copay program. And that's what they do all the time. You know, somebody will, and I think you really got to realize that just because we got financial literacy as a child or somebody taught us how to budget, not everybody got that level of education. And not everybody has the money to even budget. You know, like if you really don't have adequate money, you're not going to sit around and budget it, even though you should. So being that teacher and really spending the time necessary with them to explain it, don't just say, go make a budget. You know, a lot of people can't do that. And then helping them plug in that help that you can find, that you know about because of the job that you have. Find them a transportation grant, call their electric company and get them on the LIHEAP program. There's money out there. It's hard to find, and it's less and less every year, but there is money out there for all sorts of things that may not be their immediate need. But if you can find it, you can meet their immediate need by creatively shifting the dollars around in their household. So it's a really important lesson. I think we all can do that for friends and family, even not even in a formal advocate role, because there's lots of people around us that are struggling financially.
So Patty, you raised an incredibly important question or point during our planning session and again during your presentation. You said something like that many nonprofits use financial targets as a measure of success, like how much they program out. But you kind of asked the question like, but what about the people they're not helping? So I wanted to give you an opportunity to kind of expand on that.
Well, thank you. I think it's broader than just how we measure success with charitable foundations. It's how we measure success of our copay assistance efforts. I think in general, we have drifted into showing success using, as I mentioned, productivity metrics in terms of how many patients have we helped and what were the dollars that we garnered on behalf of those patients. And those are all really important. But it's an and we may not know today who we have unintentionally excluded. And that's, I think, the place we need to go to now, is to be able to look at, of the patients that we're supporting, what do those sociodemographic characteristics look like? And are there areas where we think we're missing certain patient populations? And ask those same questions of the individuals that we're not able to help. There are certain cultural differences between groups of populations, and we may not have the right cultural competency language to be able to really reach into those populations and support them in a way that they're comfortable. And the data is just the beginning of being able to start asking those questions, seeing if there are potential disparities, but then taking action. I love what Tiara said today about how words are words, but actions really matter. So that the data is important in that it tees up what the next steps are, which is how do we determine the disparities and how we fix them.
Great. And we talked during our planning session that there is no one size fits all kind of solution for addressing health disparities. And one of the things that we talked about is being your own advocate. So what does being your own advocate look like in the healthcare setting, and how can we creatively work around communicating with and educating patients to be their own advocate? And open up to anyone on the panel. And get ready, because it's coming to you guys next, so just FYI.
Yeah, I'll take that, Krista. I thought a lot about this question, and I think my answer is we have to find the people. We talk a lot about patients, and that's an assumption that they're already in the healthcare system. And the fact of the matter is healthcare disparities exist because there's large segments of people that are not in our healthcare systems today. They're not in our programs. They don't know about this conference. They've never engaged with an advocate. And they have very little knowledge about where to go seek even basic primary care. So I think our first step is a big one. And it's really finding the people, going to where they are, bringing resources that you may have in your organization. We designed some copay funds specifically for communities that have been identified as vulnerable by the CDC, and have been able to bring a resource that didn't exist in these communities. It wasn't in our data. We knew we weren't there. And where you live matters as it relates to healthcare access, probably more than other things, honestly. So once we find the people, then the job actually gets a little easier.
Right.
You know, we have lots of best practices and lots of tips and tricks that we can teach about how to speak up and, how to, not feel bad when you want to ask a question of your doctor or go see another doctor. And how to get on the phone with an insurance company and, how to apply for a copay grant. That's when the fun begins. But I think we've got a real uphill battle that we've got to focus on if we ever hope to kind of eliminate or improve the inequities that we have right now.
Also, I just wanted to say, Patty, you hit a big nail with a little hammer. I know you're going to hit it with a bigger hammer because I know you. But I think the cultural differences that we kind of overlook. When I was working in a hospital, one of the things that people had a hard time dealing with was when you had families advocating for patients, or patients advocating for themselves and being very firm and very strong. Some of that is actually cultural, and we have to learn what some of those differences are. There have been identified 6 cultural phenomena that can be looked at across any cultural group, and one of those is communication, how that patient communicates. We get frustrated sometimes because a patient won't make a decision. You need to get this, you need to have this, and the patient won't make that decision for themselves, because culturally, their wife is going to come in later on this afternoon and she's going to make that decision for me. So we have to get past some of that. I taught a course on this, even through the Department of Homeland Security. They hired me to teach their people how you deal with cultural differences when you're dealing with people, because that's something that you have to take into consideration when you're working with patients. You really have to. And so I think next year we're going to have perhaps a track or something on that as well.
Great. Sarah, do you have anything to add?
Yeah, I just wanted to add, education is such a huge piece. Once we get the people in, at Cancer Care, we do a lot of webinars around self-advocacy in different disease states, different populations, young adults, older adults, and that educational awareness with very practical tips on how to advocate, what to do when your medical team pushes back or when you feel disrespected or you feel like you don't have your voice. And so a lot of that is education.